Carly has very kindly asked me to talk to you about imaging the urinary tract, or the bladder in particular, but I was going to expand the discussion to the whole urinary tract because it is related. Now, I'm an interventional radiologist, which means I do procedures. It also means that everything has to be very simple for me because interventional radiologists approach things very simply. If we can't see it, we can't biopsy it, you can't treat it. So what I'm going to do is, by the end of this talk, and I call it a discussion. I'm very happy for everyone to ask me questions about this, but it essentially give you a high-level understanding of how I approach imaging of the urinary tract. So I try to break it down and make it as simple as possible, mainly because that's how I approach things. So what I was going to do was I'm going to go through all the different modalities. Some of it will be historical, but I was hoping to give you sort of an understanding of what we have and what we can use to try to image the urinary tract, particularly in this case the bladder, as from the point of how do we diagnose it, how do we stage it, and then what happens if the tumor is spread and how we can help the oncologist in treatment. So just a really brief background, and this is my understanding. Bladder cancers, the transitional cell carcinoma is most common, and that's important. The squamous cell carcinoma is only about 3 to 8% of bladder cancers. Adenocarcinoma is 1%, and other tumors are quite rare. Now, the point about transitional cell carcinomas, which is the most common, is that they can arise from any part of the urothelium, and the urothelium is the lining of the inside of where the urine collects. Okay, so that starts in the kidneys and ends in the bladder. So it involves the collecting systems, the ureters, the bladder. The tumors initially start off as very superficially and project into the lumen. Now, imaging, to understand imaging, you have to see that there's two parts of the urinary tract. There is the kidney, which produces urine, and then there's essentially the tissue that holds the urine in, okay, before it's expelled. And to do that, we need to use different imaging modalities to look at the kidney and the parenchyma, and then to look at the bladder. And then if you're looking at when the tumor has spread, to also look at how we image it elsewhere in the body and what tools we can use to do that. Now, imaging the inside of the bladder basically relies on either someone clever like Carly, who can look inside with a scope, okay, or we have to put a positive contrast agent in so that we can see it, all right? And I'll show you in the images later on what I mean by that. The second part is cross-sectional imaging, where we look at ways of reconstructing what the tissue looks like in 3 dimensions, rather than looking at a planar image, okay? So the imaging of the primary tumor relies on opacification of the urinary tract and cross-sectional imaging. And imaging for metastatic disease, so if it's spread, is for staging and also predominantly relies on some form of cross-sectional imaging, okay? Now, if we start off really simply, we talk about general X-ray, plain X-ray, where we create something like an abdominal X-ray or a chest X-ray. Chest X-rays are pretty ubiquitous and they're very good to use during treatment. So for instance, some treatments can cause problems with the lungs, and it's very useful as a screening tool. Abdominal X-rays can be good for bowel obstruction, looking for calculi, and skeletal X-rays are good to look for risk of fracture risk. So all this come up later. Now, we can't really see much else. So if we inject contrast, which is an iodinated-based agent, into the veins, it can be useful in the initial phase when it circulates around the body, but it is excreted by the kidneys. And we can use this to very good effect, okay? And even in the olden days, before CT, they used to use this. It is dependent on the kidney's ability to excrete contrast, and it produced the old-fashioned intravenous pyelogram, which some people may know, but I don't think people even make those machines anymore. It's largely been replaced by CT. The other way you can opacify the inside of the bladder is to inject contrast directly into the bladder, for instance, through a urinary catheter. Okay, so this is what an X-ray room looks like. Most of you would have seen one of these. There's the X-ray source here. Now, I'm just discussing this a little bit because how we image things depends on where we're going to get the signal from, or the source of the image. The X-ray tube is at the top, and it projects or it shines X-ray radiation onto the patient, and there's a plate that sits underneath here, and it receives the radiation and looks at essentially a shadow. So different parts of the tissue of the body will absorb the X-rays in different degrees, and that produces an X-ray. This is the upright bucky, for instance, for chest X-rays. But by and large, imaging the abdomen, you'd have the plate underneath the table and the X-ray source above it. Okay, so that's the basic configuration, and you get an image that looks like this. So if you look at the image on the right, you can see bone, you can see a bit of bowel gas. So gas is less dense, so it looks darker, and so it's like a negative contrast. You can see the outline of the kidney here, and you can see maybe the outline of the bladder here, but it's not that great. And you're not going to be able to see a lesion really on this. However, when you inject contrast and the kidneys excrete it, you can start seeing that it opacifies the inside of the collecting system. So this is the urine with contrast in it, okay? And you can see very well, this is, they've obviously selected this from multiple images, because I guarantee when I used to look at these, they never looked that beautiful. But you can see the lovely collecting system, the calyces, the ureters, and you can see it all the way down to the bladder, and you can see contrast in the bladder, and it outlines the bladder nicely. All right. The other thing I mentioned was you can, if you have a catheter in, you can inject contrast into the catheter and it fills up the bladder. The reason why you don't see it going up the ureters is because the ureters, as they enter the bladder, it goes through a longer tissue tract and it acts like a valve, so you should not get reflux. Okay, so this is one other way of imaging the inside of the collecting systems. All right, so this is the general theme. The next modality would be ultrasound. Ultrasound uses high frequency waves that's created by a transducer, and the sound is reflected from the tissue and comes back to the transducer. Now, the way this works is through a thing called the piezoelectric effect, and maybe some of the physicists in the audience may know this, probably a lot better than I do. But my understanding is it's made of crystals, which when you deform it, it creates an electric charge, or when a stressor is applied to it and it deforms, it can generate an electric charge. Okay, so that's how you send and receive. So this is the effect. The piezoelectric crystals put a current across it, and it produces sound waves. It hits the organ, and the sound waves bounces back, and you can get this appearance, which is the first type of cross-sectional imaging. Okay, so here you go. This transducer is up here. The sound waves projects down onto the tissue, and it reflects off the different surfaces, and the clever electronics reconstructs a cross-sectional image. Ultrasound is fantastic because it gives you real-time imaging of the organs you're looking at. The problem is it doesn't give you a whole three-dimensional stack of images. It's only selected images, and it really depends on the operator to see the pathology and diagnose it. The other thing you can do is you can use it to detect vascularity. The way it does that is by the so-called the Doppler effect. So when the sound wave bounces off a moving object, the frequency changes. So that way you can see vascularity in the tumor, and more importantly for a radiologist, it shows adjacent vessels if I have to biopsy something, so I need to know where my needle is going to go. it has a very limited role in the staging of bladder cancer. But the good thing about ultrasound is GPs like to order a lot of ultrasound because there's no radiation and is very accessible. And it's also a very versatile tool. And as a result, to some extent, it is a screening test. So whenever we look at the bladder, we are looking for bladder tumors. So from that point of view, very accessible, no radiation, so very little risk, nothing injected like people can be allergic to contrast or have reactions to contrast, and we can discuss that later. And from that point of view, you can occasionally see a bladder tumor. And I have, in my career, diagnosed a couple of bladder tumors that way, which is fantastic because you can pick it up early. And this is the image you get. So this is the where the transducer is. This is the bladder. So urine is dark because it doesn't reflect the sound waves. It's a good acoustic window, and the bladder should look quite elliptical, but you can see here there is this irregular lesion projecting into the bladder. So the black is urine, and this is a mass or tumor rising from the bladder. And as I discussed, we can also use the Doppler effect to look at vascularity. And this gives us more confidence that this is actually a solid tumor because it has vessels in it. Sometimes you can see debris in the bladder for various reasons, and that may not have vascularity. However, the absence of vascularity does not exclude a tumor. Okay.
And we often hear this, Kevin, some people's
Yep.
tumors are missed on ultrasound. I guess it's operator dependent.
Absolutely. It is definitely operator dependent. A good sonographer will find smaller lesions. And the other problem is that if the bladder is not well distended, you can get folds, or if there's bladder outlet obstruction, you can get trabeculation, and that can be sometimes ignored, or a bladder tumor may be ignored because they think it's trabeculation. So it's not a perfect test, but as a screening test, if it picks up a couple for free, I'm happy. The next modality is CT. Okay, CT is the workhorse of modern diagnostic imaging. It produces, it's become faster, lower radiation dose, more slices in the last couple of decades. And we are imaging things that are smaller structures, better resolution, better contrast. It's really for the assessment of the primary tumor and staging. Bladder tumors can appear as a focal thickening in the bladder or a mass projecting into the lumen. It's not very good for early stage, as in it doesn't really show you how well or how much it's penetrated into the bladder wall. But if it is locally advanced, as in if it projects through the bladder wall, it does demonstrate that. And it's also good to see if there's involvement of adjacent structures. It's the other, so the more important to some degree benefit of CT is it's also good for staging. So you can look at everything else. You can look for lymphadenopathy, so lymph node involvement in the pelvis or in the abdomen. You can look for lung, liver, adrenal, bone metastases, and other metastatic disease in other areas like the peritoneum, the subcutaneous tissue, intramuscular. Adding intravenous contrast increases the diagnostic sensitivity and specificity as well. Okay, and as I said, if we rely, or you can also leverage the fact that the kidneys excrete the contrast. So if we delay the scan or repeat the scan a bit later on, we can also see the contrast in all these other structures. Now, before I show some images, we should talk about post-contrast acute kidney injury, which was previously called contrast-induced nephropathy. And this is where we have an injury to the kidney due after the injection of intravenous contrast. There is now that is defined as a transient or increase in the creatinine or reduction in the glomerular filtration rate following the use of contrast. Most of the time it resolves. Sometimes it can be permanent. Now it is stratified. So if your EGFR, your effective glomerular filtration rate, which is a measure of how well the kidneys are working, is greater than 60, and this is measured in mils per minute divided by a factor which is to allow for surface area of 60, that's considered very low risk. Between 45 and 59, it's a low risk, doesn't stop us from going ahead. Moderate is if it's above 30 but less than 44, and a high risk is under 30. So the main numbers you need to really know is over 60, there's no problem. Under 30, there's a serious problem. And in between, we have to use our judgment. The other risk factors for acute or kidney injury after contrast is the present if someone has diabetes, myeloma because they can excrete certain proteins into the urine, heart failure, nephrotic syndrome, sepsis, dehydration. And one way we can reduce the risk of acute kidney injury after contrast is essentially hydrating the patient. So anywhere from oral fluids beforehand to intravenous saline before or before and after. Some people still use N-acetylcysteine, although I think it's not considered to work particularly well. And also to make sure you check the creatinine. So we are able to stratify the risk. But really the main protection you can offer is hydration. Now, there are other adverse effects that you can get from contrast. And this is important because they're not actually true allergies. There's reactions that are like an allergy, and then they're physiological reactions. The anaphylactic reaction is actually quite rare, but it occurs quite soon after exposure. So within 20 minutes. After 20 minutes, it's unlikely to happen. The risk factors for an adverse reaction are previous contrast reactions, family history of contrast reactions, other allergies, which essentially says that if you have other allergies, you're more likely to have an allergy to another agent. Hypothyroidism. Some of the myths is shellfish allergy does not correlate with iodine allergy. Previous hypersensitivity to other iodine-containing compounds. So some people say, you know, when we put some alcohol on this iodine on the skin, I had a rash. That does not correlate with a contrast adverse reaction. And if someone does have an allergy, firstly, we have to decide whether we're going to give contrast at all. And if we decide we're going to try to reduce the risk, we can use some sort of corticosteroid, oral prednisolone, and an antihistamine. But this does not completely prevent the risk of anaphylaxis. Okay. Sorry, one more boring slide before I get to some pictures. If we stratify the adverse reactions, mild is self-limiting. So these are not really allergic type reactions. They're nausea, vomiting, flushing. Part of this is because the contrast actually causes some vasodilatation. And some people can get some urticaria or a rash afterwards. And this is really treated with nothing. It's the supportive care, watch the patient. It can be moderate. So urticaria, the rash becomes worse, you get more vomiting. And then we get into the things that cause radiologists more concern, like bronchospasm. If you start wheezing, you get edema around your face, your voice becomes hoarse, so you're getting laryngeal edema, or your blood pressure changes. And the treatment for this is antihistamine, intramuscular adrenaline, oxygen, and things like Ventolin. The severe reactions are very rare, okay, but they can be life-threatening. So we're talking about a cardiac arrest, respiratory arrest, pulmonary edema with this fluid in the lungs, cardiogenic shock, convulsions. And this requires essentially the same oxygen, adrenaline, IV fluids, but at this point where radiologists would have to enlist the help of other people. So in the case of Macquarie, we're very lucky. We have an intensive care department that will descend on us if ever we needed it. Delayed reactions, which is 1 hour to 1 week, are usually just mild skin reactions, and they're not that common. Okay, so what does a CT scan look like?
Well, Kevin, before you
yes,
before you go there, why does the CT contrast scan make you feel like you've wet yourself? Is that something you've ever had patients tell you? Is it from
absolutely. It's from the vasodilatation in the pelvis.
Okay.
I get it a lot when I do angiography, and we do runoffs where you have the contrast going straight down the aorta into the pelvis, and people get that sensation that that they've wet themselves. Yes.
Explanation.
Okay. Okay, so this is what a CT scanner looks like. Everyone's seen one. There's a table, and there's this contraption with a hole in the middle. What's happening in here is that it's exactly the same configuration as your X-ray table. There's an X-ray source at the top, and there's detectors down the bottom. Okay, the X-rays are in a fan, and so they irradiate this whole area, and this is broken up into multiple layers of detectors. Okay, so in the case, so they're now sort of in multiples of 64. When I started, you used to get 4 slices, 16 slices. Now pretty much all of them are 64, 128, or 256. Now, just on the physics side, because I love the physics, as you get to wider and wider fans, so the distance from here to here, you actually get more artifact from the edges. So going wider doesn't actually mean better pictures. The other thing is that this is not just a fan beam, as in it rotates around and you take an image. As it rotates around, the table actually moves at the same time. So you actually get a helical acquisition, which is why you can scan the whole patient in literally seconds. It scans so fast that we can actually capture contrast in the arteries, and we can have angiography. And in fact, when we image the abdomen to the legs, the scan can actually be so fast, it actually outruns the contrast. So when we actually image the legs, we actually have to slow it down, which wasn't the problem in the olden days. In the olden days, we couldn't keep up, but the scanners now are so fast. But it results in amazing imaging.
Kevin, before you go on, there's
Yes.
another question. Is there a big difference between the various types of CT scanners? And can there also be a difference between the radiologists in the detection of bladder cancer? You may or may not choose to answer that part of the question.
Okay, the answer is, in terms of the technology, the scanners, about 20 years ago, the 3 main vendors went down different paths. So the Siemens scanner said speed is all that is more important. And in order to get speed, so these things, to give you an idea of how fast this whole contraption is spinning around, it's something like 3 times a second. Some of them are now supposedly rated at 0.25 of a second rotation, so 4 times a second, but they've never actually been able to do that because the G-forces on the equipment makes it fall apart. So even though the electronics can keep up with it, they have never actually been able to produce one that I'm aware of, or that they're trying to sell us, that can actually do that. So Siemens went for speed, and to increase the speed, they actually had 2 of these things at 90 degrees to each other, okay? GE went down the track of saying, we should improve the detector quality in the detectors. And they produced what they call the gemstone, which produced or actually used more of the radiation to create the image, which meant that you can have less dose. Toshiba just said, forget about speed or detector quality. I'm just going to put more and more detectors on, so I made this wider and wider. And as a result, I was not that crazy about Toshiba, but what they could do really well was, because they had such a good coverage, their cardiac imaging was fantastic because they could cover the whole heart in one heartbeat. So it's pros and cons for everything. In terms of radiologists, and this is one of my soapboxes, is no, not all radiologists are the same. Radiology has absolutely exploded in the last few decades. And as a result, it is impossible to know everything. And as a result, you tend to gravitate to the imaging that you are more interested in. And as a result, I think you are a better radiologist if you report in your area of interest. So we now have radiologists. So for instance, myself, I'm interested in oncology intervention. So I do a lot of the cancer staging. A lot of that is because I will have performed procedures such as biopsies or other procedures on the patients. So it's become my interest. I don't have any interest in musculoskeletal imaging, so sports injuries and MRI of joints and things. I don't report that at all. There are people who only specialize in that, and it's an absolutely extraordinarily large area field of expertise. And you can spend a lifetime and not even scratch the surface. Same thing with the stuff that Jessica Yang does, for instance, which is MRI of what they call body imaging at the moment. So essentially liver, pancreas, uterus, bladders, kidneys, and using MRI to image that. And I'll talk briefly about MRI later. So yes, I think we're probably coming to the point in where really we should start not referring to a location. You should start referring imaging to a particular radiologist, because it does actually make a difference. So for instance, do not refer MRI knees to me.
Suppose with radiology, I guess it doesn't matter if patients are on remote locations, images can be sent to other facilities for them to be reviewed elsewhere. Is that correct?
And that is actually standard practice now. Every radiologist. So in the olden days, they used to say, I do teleradiology. So I've got a workstation and someone sends some images to my workstation and I report it. PACS, which is the Picture Archival Communication System, which is how we share images or we review images, is now everything's in the cloud now, which means that I can report from home and we can report from pretty much any location. And one of the things that I'm interested in is being able to take that expertise to everyone. So if you have someone who's an expert in a particular area, someone has an expertise in MRI of the pancreas, for instance, that expertise should be available to anyone in every city across Australia. Anywhere where there's an MRI, there is no reason why that radiologist could not be specifically referred a study to image the MRI and report the study, because the technology is there and we use it all the time. The thing that is not there is the networks and the communication, or really the social structures to allow that to happen. Technologically, we can absolutely do it, but we just don't. And I think that is a situation that we need to fix. Okay. So here's the sort of image we get. So just to, I think you probably know what this is. This is the pelvis. So we're looking at the person from the front. So this is the right side and this is the left side. So you can see a bit of the kidney there. This is a bit of the liver hanging down. There's the other kidney. And here's the bladder sitting in the middle of the pelvis. So this is the femur, the femoral head. That's the other femur. And here you can see the outline of the bladder. And inside the bladder, you can see there's a mass lesion. So there's a couple of things I can say about this. Firstly, this is done with contrast. So we've injected contrast into the patient, And there's a certain timing as to when organs opacify. The standard is approximately 90 seconds after injection of contrast to get an image like this. And that's typically when most organs opacify optimally. There are a few variations on that. So for instance, if you want to image the vessels, like the artery just here, you want to image it about 25 seconds. And if you want to image the kidney well, then the kidney has multiple different phases. So if you look at this kidney here, the cortex opacifies at this point. The less dense bit here is the medulla. So you can give a cortical phase, a corticomedullary phase. If you wait long enough, it starts excreting contrast, which we'll see in a moment. Now, this is done early on. So before there's contrast excretion, so there's no contrast in the bladder. But what this does show us is you can see the edge of the bladder just here. So we know that macroscopically, this lesion has not penetrated through the bladder. This is the rectum. We know that it has not invaded into the rectum. It seems to be just projecting into the lumen of the bladder. You can see there's some enhancement as well, and there's a little bit of enhancing tissue here. And you can see that here as well, where it's a little bit irregular, but you can see enhancement. So this means this is there's some vascularity in this lesion. The other thing is we start looking for other things. It's not good enough to just say, okay, I saw this lesion. I need to look at other things. Where will this spread to if it does spread? So we're going to start looking around in the pelvis along here for lymph nodes. So when we wait a bit longer, the kidneys will excrete the contrast and they'll start filling up the bladder. And then you get an image like this. So here's the white is the contrast being excreted. And this is the unopacified urine. And you can see the structure sitting inside the bladder. And I've just blown up that image to show you that you can see a little bit of the wall of the bladder. And you want to look for other changes, like has this penetrated through the wall of the bladder? Admittedly, CT is not great for that, to look for small amounts, but it will show macroscopic disease. And then we need to start looking at staging this lesion. I want to look further afield. I want to see if it's gone to the lung. I want to see if it's gone into other lymph nodes. Now, when I started the discussion, I said we're going to image the whole urinary tract. Now, the kidney actually produces the urine, so that's in fact going to be the first place where you're going to see opacification, and you get this sort of image. So remember our first image where I showed the. In fact, what I might do is go back to remind you. So I'm going to skip all the way back. Sorry. Oh, there we go. That's the image. So you can see that you can see a bit of the outline of the kidney here, and you can see the collecting system. So exactly the same principle, except we've imaged using the CT. And so we're going to get a lot more detail of the parenchyma. So we can see the kidney, here's the cortex, the medulla. You can see the fat in the renal sinuses. And here's a filling defect in the upper pole of the kidney. Here's another mass lesion that's sitting in the renal pelvis. Okay, so CT. The next is MRI. MRI is extremely complex, but to make it really simple, MRI it does not use ionizing radiation. So X-ray and CT, we're using X-rays, we're irradiating the patient. MRI uses a different way of imaging the patient. In fact, what MRI does is it just looks at the hydrogen nucleus. So hydrogen is in pretty much every tissue. Hydrogen is in fat, is in water. When hydrogen is exposed, because all it is really a proton, when it's exposed to a strong magnetic field, it tends to line up, okay? And we exploit that to actually produce the image. It gives excellent soft tissue characterization. And the way we, or the machine can do things to the aligned hydrogen will give you different signal strengths of different tissues. So we can start using different sequences. Plus we can use gadolinium as a contrast agent. to image the tissue and to help characterize lesions, soft tissue lesions, as well as bone lesions. Now, the thing about MRI is, so CT is really fast these days. You can image the entire body in seconds. With MRI, sequences may take minutes, okay? So it means that a whole MRI scan will take about 20 to 30 to 40 minutes, depending on what you're looking at and how complex the problem is. It's also not a screening study, okay? You don't say, well, just let's stage this cancer with MRI. It's very different to CT. You're asking specific questions about specific organs, all right? As I said, it can take a long time. Every sequence can be several minutes. The shortest sequences may be about 90 seconds or so. It's because the patient has to lie still, it is susceptible to movement artifacts. So within that couple of minutes, if you move, it ruins the images. The other thing is the aperture or the bore of the magnet is actually very small. So people do get claustrophobia. My wife is terrible. I cannot get her into an MRI scanner. Other people, it doesn't even bother them. It's also because of the problem with the length of the sequences, it's not great for organs that move, okay? So the heart needs very specific imaging, and heart is specific. They can actually do cardiac gating because the heart actually moves in time. So if you can predict how the heart is moving, which is okay if you have a nice calm patient and the pulse is 60, you can use cardiac gating to image during certain times of the cardiac cycle, and you can effectively freeze the motion of the heart or get cine images of the heart. The diaphragm is a bit harder. People have tried respiratory gating, doesn't work so well. So imaging around the liver can be tricky if you cannot get a sequence done within a breath hold. The other thing is it has a very strong magnetic field. So magnets can range in strength from 0.5 Tesla to 3. Some of the research magnets go up to 7.8. I can't remember. But these can cause problem with pacemakers and nerve stimulators. Also, if there are metal foreign bodies in the body, that can cause artifact because it distorts the magnetic field, and they can also move. So for instance, if people are metal workers and they've had splinters in their eyes, the iron filings can actually lodge in the retina, and if you put them in a strong magnetic field, it can actually cause retinal detachment. So it's one of the things that we are very, very cautious about. As with anything we inject gadolinium. Gadolinium is a heavy metal. Some people can have a hypersensitivity to it. The other thing is, which makes me a little bit uneasy, is that it's known to deposit in some tissues of the brain, and no one actually knows what effect this has long term. Although we have been doing this for decades now, and no one's actually been able to prove there's been ever a problem. So I'm assuming it's okay. There's also a thing called nephrogenic systemic sclerosis, which is a very debilitating, I think lethal condition, but it's extremely rare. And it occurs in people with renal failure with specific contrast agents. Now, gadolinium is the thing we image, but how it is, we don't just inject that into the body as an element. It's actually wrapped up in a larger molecule. Now, the more modern agents or carrier agents have a three-dimensional structure, and they actually hold the gadolinium tighter, and so they don't unfold in the body and doesn't release free gadolinium, which is what causes the problem. So those linear agents are now banned, okay? And those linear agents were the ones that caused the problem. So although many sites, including MMI, will not give gadolinium under with a renal impairment of an eGFR of less than 30, it's not an absolute contraindication, and it really has to be weighed against the benefit of doing the scan. Okay,
So
so
a
yep.
question came up. You've answered most of it about severe gadolinium toxicity. Are there any treatment options? Are there any experts or studies in Australia about gadolinium toxicity?
Oh, I have not researched that recently. I don't know, but in terms of the nephrogenic systemic sclerosis, this is extremely rare. And so I don't know if there's any treatment for that. In terms of the hypersensitivity, it's treated exactly like any other allergic reaction. Supportive care, depending on what it is like. And the main thing is, if it's a significant reaction, don't have more gadolinium, avoid the agent. Okay. In terms of the depositing in the brain, I'm not entirely sure. No one's actually proved that that's actually caused the problem.
Thank you.
Okay. So this is what an MRI looks like. You can see it is much longer than a CT scanner because you have to go all the way into it. This is a very strong magnet, and it has a lot of electricity running through it. There's helium to cool it down to make it a superconductor to get that magnetic field strength. And inside this room, you really shouldn't take anything like credit cards because they won't work when you come out. Watches, iPhones, anything like that. So if you have a magnetic field, these are the hydrogen nuclei, the protons, and they will tend to line up, okay? When they line up, they form a vector, and the way it's similar to the ultrasound. So we have all these hydrogen nuclei lined up in the strong magnetic field. Across that, and you might see it here, this thing over here is called a head coil, okay? You need a coil to start perturbing these hydrogens, okay? So in this coil, there are another whole bunch of, there's other coils inside this, okay, which actually send a radio frequency pulse across the hydrogens. And what that does is it tilts it. So these things are in the magnetic field, happily spinning away. We hit it with a pulse of radio frequency, and it tilts, okay? It then tilts, and when we release that pulse, it then goes back to where it wants to be. And in that process, it re-radiates energy, and it's picked up by this coil. So these are called send-receive coils, similar to the ultrasound principle. You put an impulse in, you get something back. And as a result, so the other thing is how these behave depends on where it is. So hydrogen in water will behave differently to hydrogen in fat, behave differently to hydrogen in muscle, okay? And as a result, you get exquisite soft tissue characterization. So you can compare this with the CT. Here you can see the bladder wall very nicely, whereas the CT was all a little bit gray and fuzzy. This is also gray, but it's much easier to see tissue definition. Muscle becomes, you see more of the structure of muscle. You can see the planes between the muscle. You can see the cortex of bone. You can actually see the trabecula and the fat that's in the bone. So here you can see the two. So these are two standard sequences. So this is called the T2 weighted, where you see the fluid as white, and the T1 weighted, where you see fluid as black, okay? If we gave contrast, we would do it on this sequence, and it would make this lesion enhance. They can either do also clever things as well, where if you have a fluid sequence, you can actually do another pulse across it, which suppresses the fat. So it makes edema and fluid in the tissue stand out better. There are an infinite number of sequences that people can create to image the body using MRI. And this is an area of enormous amounts of research. And as I say, people who do MRI often just do MRI and nothing else. And often they will just do it in one body system because these fields are becoming more and more sophisticated all the time. Okay. Before I get on to the nuclear medicine, the other thing that is more along Carly's line of work is the retrograde parallelogram. So radiologists are allowed to inject contrast into the bladder But Carly can do things that are even more exciting. He can inject it straight into the ureter, and he can see a path right from that way. I just use that to contrast the cystogram. Do you want to say something, Carly?
Yeah, just going back. Thanks for that. Yes, quite fun doing these procedures and being our own radiologists. But going back, there was a question. People apparently have gold mines in their mouths. Lots of different kinds of metallic implants. Is that a
Yes,
problem at MRI?
it can be. So if you are imaging the base of skull or the head and neck, anything that has ferromagnetic will cause artifact and will distort the image. So if you're reliant on a perfectly uniform magnetic field and you put iron into that magnetic field, it distorts the magnetic field, and then you get distortions around the metal. That is a problem. However, if you have metal in your mouth, most of the time it's probably been there for a little while and it's pretty much locked onto your teeth. It's not going to move. Okay. If you have a recent cardiac stent, most of them now are not, or now they are MRI compatible, so there's usually not a problem. But if you have something in, something that where you're concerned it might move, so in an aneurysm or something like that, then you have to make sure that it is MRI compatible, or you just have to wait long enough until it gets embedded into the tissue. In terms of gold in the mouth, I don't think gold is ferromagnetic, so it shouldn't be too much of a problem. And if you're imaging the pelvis or the abdomen, artifact or caused by distortion of the magnetic field of the mouth is not going to be an issue. Oh, the other thing that can happen is because these machines are putting energy into the body to get a response. If you do have metal, so some people have metal rods in their back or metal rods in their femurs, for instance. And if you're imaging that particular body and you're putting the radio frequency pulses across it, it can actually cause heating. So these things can warm up. Now, you don't feel like it's burning, but some of the sequences, for instance, for cardiac imaging, they actually put so much energy into the body, the patient actually comes out in a sweat afterwards. So we have to be very careful about energy deposition into the patient. Okay, now disclaimer, I am not a nuclear medicine physician. So this is, so I can't answer too many difficult questions about this. I have done some research in PET many decades ago, so I know a little bit more about PET. So if we go back and look at imaging using X-ray and CT, that is an external radiation source. We are shining X-ray beams onto the patient, whether that's in a CT scan or an X-ray, and we're looking at the shadow and we're reconstructing the shadow. With ultrasound, we are putting sound waves into the body and we're seeing what comes back and using that to reconstruct the image. With MRI, we're lining up all the protons in a strong magnetic field and we're putting a radio frequency pulse into the body and waiting and listening to what comes back and reconstructing that echo and creating an image, okay? Nuclear medicine is now different. We are injecting something into the body, all right? So this requires a way of carrying a radioactive tracer. So the radiation is not from external, it's internal, okay? So we need a substance that's going to decay, that's going to release radiation, and we're going to pick up that radiation as it leaves the body, all right? So there's two ways you can get radiation. You can get something very heavy, like technetium, which has a atomic weight of 99. So if you know, for instance, uranium is 250 something, and that's very heavy and they decay with radiation as well. Or you're going to use something very light, which you have changed and see the radiation that comes out of that. And that's where PET comes in, and I'll talk about that in a moment. The workhorse of nuclear medicine is technetium-99m, M meaning metastable. So it decays from 99m to 99, so it doesn't really change. So that is the tracer that we are looking at. You also need a carrier molecule that you're going to stick the technetium onto, and that's going to determine where it goes to, okay? So it's fine to image the technician, but we have to make sure it goes somewhere. In the case of a bone scan, the carrier model is a biphosphonate, okay? So that's going to deposit, because it binds to hydroxyapatite crystals, which is essentially bone. It's going to bind to bone, and it's going to show regions where bone is turning over. So bone activity, exposed bone, all right? The one they use is MDP, which is methylene diphosphonate. And now the thing about a bone scan is it's actually a really, really low radiation dose. You get less dose out of it than an X-ray, okay? You don't need any preparation. You do need to lie still for the scan. And it also relies on good renal function to ensure that excess tracer is excreted and not deposited into the soft tissues, because all you want to do is look at bone. Okay, so here is what a PET scanner or a standard nuclear medicine scanner looks like. Now, there's actually two components to this. You can see here, there's a flat panel and a flat panel here. And this is sort of like the old X-ray, where you just have one panel and you're looking at it from a planar two-dimensional field. The other thing that you can do is this thing can rotate around, okay? And it can create a CT-like image. Now, nuclear medicine was also called, you interchange the N and the U and you get unclear medicine. It looks very fuzzy. So you need anatomical detail. And so what they've also done is they've actually glued a CT scanner onto it as well. So this contraption at the back also has a CT scanner in it. So not only do we take images using of the technetium decay, okay, we're also going to put the patient through the scan, and we can do a CT scan and we can line them all up. Now, I haven't got an example of that with SPECT. This is single photon emission computed tomography, and I'll explain that in a moment. Yeah, let's explain that right now, actually. So technetium 99 indicates technetium 99, and it releases one gamma particle, okay? So a patient sitting here and the particle races off out of the body and is picked up by the detector, and you're going to get an image that looks like that, okay? So this is a planar image. It's sort of like the equivalent of an X-ray for nuclear medicine, and it shows uptake of, so there's normal bone uptake with this agent, but then you're looking for places with additional uptake. So this person has, unfortunately, metastases in their spine, and you can see them deposit here. And this doesn't show you the tumor, it shows you the reaction of the bone to the tumor, okay? Now, there are some disease processes where it does not cause, it just causes holes in the bone without the bone turnover. So myeloma, for instance, does not actually show up on a bone scan. Okay, so that's bone scan, not really my area of expertise. I have done more work in PET scanning. This is similar but different. Okay, once again, we have to inject something into the body, and it has, so an isotope in the body, and we have to have a carrier molecule. So with PET, it uses a different, and I'll show you the physics of it because I think it's quite interesting. But it uses smaller molecules. So technetium was atomic weight of 99. Okay, this is 18, so it's smaller. It's fluoride. Okay. Now the problem is this has to be produced fairly quickly and used very quickly, because the way these PET isotopes are made is they're made in what's called a cyclotron. A cyclotron is a machine that accelerates protons, so accelerates it fast and fast and smashes it into a target, and the target then changes. Now, in the case of F18, the target is actually just water, and what happens is you smash a proton into an oxygen and turns it into a fluoride. It turns it into F18, which will then decay. Now, technetium 99M has a long half-life, so you got plenty of time to image. F18 has a half-life of 110 minutes. So every 110 minutes, you only have half of it left. So you have to use it pretty quick, okay? The other thing about a small molecule is that you can attach it to something that is more physiological, okay? Now, in the case of the workhorse of PET, which is fluorodeoxyglucose, this is actually just glucose that's been modified a bit. Firstly, they've added a fluoride onto it, which happens to be radioactive. And secondly, they've deoxygenated part of it. And I can go into the chemistry of that if you're interested as to why we do that. But just suffice it to say, this is a glucose analog. This is going to go into tissue that uses sugar. Anything that is hungry for sugar, it will take up. The other one is that Carly probably refers a lot of is the PSMA scans, where they use molecules that target this particular membrane antigen, and it's really, really good for prostate cancer. Once again, they label it with F18. Okay. Now, the study is a lot harder to conduct, and I'll only talk about FDG, which is a glucose analog. You have to fast for this because you want to have a low sugar in your blood. And the reason for that is because you don't want any insulin around. Insulin makes body tissue take up sugar. So if you have lots of insulin in your blood when you're getting the FDG, it'll go into all sorts of tissue like muscle and everything else. And that will make the study less sensitive, okay? It's an intravenous injection. You have to lie still in a warm room for 40 minutes to let the FDG get taken up into the tissue that you're interested in. So tumors, infection, or obviously tumors in the case of PET, and that takes about 40 minutes. And I'll talk about the CT afterwards. Once this is taken up, they take you to the PET scanner, and once again, it's the same arrangement. So you have detectors around the outside. The radiation comes from the patient. And you can see that this is the same configuration. It looks like a CT scanner. In fact, the front part is the PET scanner. The back part is actually a CT scanner. So they've glued a CT with the PET, and they do that for a very good reason, okay? And I'll explain that in a moment. So this is the configuration of the PET scanner. So before we had, with the bone scan, you had a plate and a plate, okay? In this case, they've got detectors all the way around, all right? There you go, well, why don't they do that for the other scan as well? Well, they probably could, but they do this in PET for a specific reason. The fluoride 18 is proton heavy compared to normal fluoride. So it has one less neutron than it should. And as a result, it doesn't like that imbalance. It tries to turn one of the protons into a neutron, and it does that by releasing a positive electron, okay? And that's where the positron comes in. The positron is ejected from this nucleus because F18 is unstable. Every 111 minutes, half of it does this, okay? And you can imagine there's positrons, and positron is actually antimatter, okay? It finds an electron, and they smash into each other, and they turn into two photons, okay? And they head off in opposite directions. Now, this is a really good thing to happen because the electronics in this machine is so amazingly fast that firstly, it can pick up when those two photons hit, which gives it 2 bits of extra information. One, it tells the machine the slight difference in timing, so it knows where or when each particle came from along the path between the detectors, okay? And this is called coincidence detection, okay? It is why PET scanning has a much, much, much better resolution than the single photon scanning, all right? And as a result, it can reconstruct an image. Now, the problem is there's attenuation of the radiation. Firstly, as these photons move through the body, they get partly absorbed by the body, which means that the skin gets overrepresented. Now, if you look at the images from the old-fashioned PET scanners many, many years ago, they all look like remember the Michelin Man? They really like bubble people, okay? Because the skin was overrepresented. So the CT scanner does two things. It allows correction for attenuation. So from the CT, you can work out the density and you can say, well, something that comes from further inside, the patient should be boosted. We should increase the value of that, and anything coming from the skin, we're going to suppress that. And you get much better representation of the actual activity in the tissue, okay? The second thing that some sites do that others don't, and Macquarie Medical Imaging is one of the sites where we do this as much as possible, is we do a diagnostic CT at the same time. So the CT that is done just for this so-called attenuation correction to give you nice PET images is not diagnostic quality. And we find that actually improves the diagnostic yield of the CT of the whole study together. And the other thing that we do that's a bit different is we actually report these studies with a nuclear medicine physician and a radiologist at the same workstation looking at it together. And so every Monday morning, I will sit there with the nuclear medicine physician and I'll give my input as a radiologist and she'll provide her input, or because I only work with the same radiologist, the same nuclear medicine physician, and we will decide together the relevance of what we're looking at. And I think that produces a better result. And partly this is because I have an interest in PET from my earlier research. Okay, so PET, so FDG deposits in any tissue that uses sugar. Okay, problem, brain uses lots of sugar. It's a main fuel source for the brain, which means that it's not really good for brain tumors. Cancer cells and inflammatory cells, it takes it up very well. It does correlate to some extent with tumor grade, and it is very sensitive, so you can see small deposits, okay? One of the problems with anatomical imaging in radiology is that we look at morphological features. So if a lymph node is 1 centimeter or less, we say it's normal. If it's more than 1 centimeter, we say, well, better look at this. If it's more than 15 millimeters, we say it's definitely abnormal, okay? That's not a very clever way of doing things. However, regardless of what the size of the tumor is, if there is FDG uptake into it, we know that there's a problem, okay? The other thing is the change in the uptake can also show a metabolic response to treatment. And in fact, that was actually my original research. We were trying to use PET to assess response to treatment early on. The other agent is PSMA PET, and this is targeting the antigen on the prostate, on the prostate membrane. I just mentioned this because the other thing you can do is F18 is pretty harmless, okay? Lutetium-177 is nasty, okay? If you take something nasty and you put it onto the same carrier molecule, and these things get stuck to the tumor, guess what happens? You now have the magic bullet, okay? And the so-called theranostics actually is very good for metastatic prostate cancer and can actually provide a lot of symptomatic relief from people with bone pain and hematuria and other things. But Carly probably knows a lot more about that than I do, so you have to direct the questions to him. And these are the amazing images we get. So this is the CT scanner, okay? And this is the PET, and this is what happens when we put them together, okay? So this is the CT, so this is an MRI here, but this is the CT scanner, this is the PET only, and this is the PET co-registered. And you can see it greatly improves the diagnostic utility, because not only can we see anatomical details, we can also see the metabolic activity. So here's a tumor, it's necrotic in the center, okay, centered on where the bladder should be, and we can see there's a deposit on the in the pelvic sidewall. You can see that here on the reconstructed, or we reconstruct something that looks like a planar image. So you can see uptake in bowel, you can see uptake or excreted contrast in the kidney, and you can see down here is bladder, but up here, this is the tumor with this deposit on the side, okay? Here's another example. The other thing is that the reason why I put this up here is you can see there's a deposit in the rib as well. Tiny little thing up here. So very, very sensitive. The other things I can point out is this person was probably moving their head during the uptake period. So you can see some uptake in the sternomastoid muscle just here. Okay, that's why we want the patients to be very still during this uptake. Okay. Here's another example. This is just gas in the bowel, but here we can see there's a bit of thickening on the side of the bladder. Here's the uptake, but more importantly, this tiny little thing here, that's actually an involved lymph node. If you said to me as a radiologist, what do you think of that lymph node? I'll go, oh, it's less than a centimeter. I'm not interested. But putting the two together, you've now just completely changed the staging of this tumor, which is very, very important. Okay, so here's another example. This is uptake in the bone. So you can see very easily that's actually sitting right in the scapula. If you peer into that, you can see there's not really that much you can see in the scapula, but there's definitely something in there, and that's important. And here's a deposit in the liver where we said, well, what is that? And someone may have said, Kevin, can you biopsy that? We don't know what it is. And I'll go, that's in a really difficult location. But the PET gives us the answer. Okay, that was all I was going to say about diagnostic things. A brief word about interventional radiology, because I'm an interventional radiologist. I do help with Akali and other urologists with things. We can access the kidney for a number of reasons. We can do biopsies of kidney lesions. We generally don't biopsy bladder tumors. We can biopsy lymph nodes next to bladders. We can biopsy the lung and liver. We can also access the kidney to decompress it in the case where there's ureteric obstruction, if it cannot be fixed from below. And we can also put in ureteric stents. So that's really where we are up to with urinary tract intervention. A lot of the procedures I do with ultrasound and CT, but the angiography room looks something like this. Once again, it's the same configuration. You see, radiology just keeps rehashing the same concept over and over in different ways. Here's the radiation source, and here's the detector, and this is the interventional radiologist next to it. Yes, we do get a lot of radiation, which is probably not a great thing. We can see the images on real time, and that helps us be able to access the kidney as well as insert stents and various other things. Floating table, and the C-arm offers very good angulation of the tube and the detector, so we can look at things from different angles. So in summary, X-ray, CT, external radiation source, ionizing radiation, ultrasound and MRI do not use radiation. Same principle, we put energy into the body and we see what comes out. Bone scan and PET is nuclear medicine. We inject the radiation into the patient and we see where it deposits. And so these ones are more anatomical imaging, and these ones are so-called molecular functional imaging. Thank you.